Bismillahirrahmanirrahim. Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera diucapkan kepada hadirin yang sudi menyertai webinar Bicara KRI pada hari ini. Saya Hawati Abdul Hamid, moderator untuk webinar pada petang ini. Baik, Bicara KRI pada hari ini bertajuk Building Resilience in Health Protection, merupakan bahagian terakhir dalam siri kajian perlindungan sosial di Malaysia yang telah dilaksanakan KRI pada tahun ini. Perbincangan pada petang ini adalah berdasarkan kepada kertas kerja yang diterbitkan pada hari ini bertajuk Health and Social Protection Continuing Universal Health Coverage, iaitu satu kertas kerja khas yang kita terbitkan di bawah laporan utama KRI bertajuk Menongkah Badai ataupun Building Resilience Towards Inclusive Social Protection in Malaysia yang telah kita terbitkan pada September yang lalu. Untuk makluman, dalam laporan Building Resilience ataupun Menongkah Badai, KRI telah mencadangkan pendekatan perlindungan sosial sepanjang hayat bagi meletakkan asas yang kukuh bagi setiap individu di Malaysia agar mampu menangani risiko-risiko utama dalam setiap fasa kehidupan ataupun apa yang kita namakan sebagai life cycle approach to social protection from cradle to grave. Bagi yang telah mengikuti webinar-webinar sebelum ini, kita telah membincangkan tentang cadangan agar diwujudkan skim manfaat kanak-kanak sejagat sebagai salah satu jaminan sosial semasa zaman kanak-kanak. Bagi individu dalam usia bekerja, kita telah mencadangkan beberapa kaedah agar skim perlindungan sosial dapat diperluaskan kepada semua pekerja, tidak kira dalam sektor formal dan tidak formal, serta semua yang berada di dalam dan di luar tenaga buruh. Dan untuk jaminan penempatan semasa usia tua, kita mencadangkan agar diwujudkan pension insurans sosial untuk semua warga emas di Malaysia. Namun terdapat satu risiko yang dihadapi semua tanpa mengira peringkat usia, iaitu risiko untuk jatuh sakit. Tidak kira tua atau muda, kita semua terdedah kepada bencana, kemalangan dan penyakit dan mungkin kita tidak dapat sembuh sepenuhnya. Oleh itu, bagi membincangkan aspek perlindungan kesihatan sebagai cross-cutting issue dalam sistem perlindungan sosial, sukacita saya ingin memperkenalkan ahli panel yang akan bersama-sama kita pada petang ini, iaitu pertamanya bersama kita ialah Saudari Nazihah Muhammad Noor dan Saudari Iliana Syafiqah Mukris Mudaris, iaitu penyelidik KRI yang juga merupakan penulis kepada kertas kerja yang telah diterbitkan pada hari ini, yang akan menjadi asas pada perbincangan kita pada hari ini. Kemudian saya ingin mengalu-alukan kehadiran tetamu khas kita iaitu yang berbahagia Datuk Profesor Dr. Adibah Kamaruzzaman, Profesor Perubatan dan Pakar Penyakit Berjangkit daripada Universiti Malaya. Selamat datang Prof. Kami amat-amat berbesar hati menerima kehadiran Prof. Serta juga bersama kita pada petang ini tidak asing lagi iaitu yang berbahagia Tan Sri Nur Muhammad Yaakob, Pengurusi KRI. Dan juga seterusnya, jika dilihat atur cara untuk ringkas pada petang ini, di mana kita akan memulakan bicara KRI dengan pembentangan oleh Nazihah dan Eliana, diikuti dengan ulasan daripada Profesor Adibah. Untuk makluman semua, perbincangan semasa slot ini akan kita adakan dalam bahasa Inggeris. Dan selanjutnya kita akan menjemput yang berbahagia Tan Sri, dan seterusnya kita akan menjemput Prof. Adibah untuk membuat ulasan. Dan kita juga akan mendengar daripada Tan Sri untuk membuat rangkuman keseluruhan perbincangan pada hari ini. Setelah mendengar pandangan daripada semua panelis, kita akan membuka sesi webinar ini dengan memberi ruang bagi sesi soal jawab kepada hadirin sekalian. Justru itu, saya ingin mengalu-alukan semua untuk menghantar sebarang pertanyaan, tidak kira dalam bahasa Malaysia ataupun bahasa Inggeris, melalui butang Q&A di platform Zoom ataupun melalui ruang komen di Facebook Live. Baik. Jadi tanpa melengahkan masa, saya ingin menjemput Nazihah dan Eliana untuk membuat pembentangan mereka. Dipersilakan Nazihah.
Thank you, Hawa, for the introduction and for summarizing some of the key findings of KRI's recent work on social protection. And thank you to the attendees and to Prof. Adibah and to Tan Sri Noor for joining us on for this webinar today. So first, I'd just like to point out that much of this paper that Ileana and I co-authored is built on, as Howard said, existing work. That's one of them is the Building Resilience report that Howard just summarized earlier. The other one is a report called Social Inequalities and Health in Malaysia, which KRI published in 2020. Next, please. So just as a quick recap of the 2020 KRI report, we know that Malaysia's health system has performed well overall for several decades with many major improvements in key indicators of health outcomes. Without going into too much detail, from 1970 to 2020, life expectancy for women, for example, has gone up by 12 years and by 10 years for men. And we've also seen amazing decreases in child mortality rates and maternal mortality rates, as you can see in the charts on the right. But the progress has been moderating in recent years. You can see, there's a plateau for these indicators, even before we start taking into consideration the effects of COVID-19. Not shown on this slide also is the fact that much of the gains in life expectancy in Malaysia are actually years that are lived in poor health, with a higher concentration of poor health in the lower socioeconomic groups. So this stagnation in health performance and inequities in health improvements might be a reflection of a health system that has served us well in the past, but is under-equipped to face the current and potentially also future challenges. So we, now the 2018 Auditor General's report is now quite infamous for the prescient warning that it gave us that the Malaysian public healthcare sector is underfunded, understaffed, and overcrowded. Next, please. So vulnerabilities in the public healthcare sector in Malaysia can threaten the overall healthcare system, which then puts the entire Malaysian population at risk because health protection is an important part of social protection. Next, please. So in the Building Resilience report that Howard summarized earlier, we propose policy recommendations to protect individuals against age-specific risks for children, working age, and the elderly. But in addition to these age-specific risks, there are also health risks which cut across life stages, because every individual faces a potential loss of health at some point in their lives, whether it be in the form of illnesses, a disability, or death. In 2019, on average, each person in Malaysia lost about 2.8 months of the year to ill health, with about 73% of it due to non-communicable diseases. Next, please. So aside from the intrinsic value of health, it's also an economic asset. Those who are healthy are able to seek gainful employment and make income, which they can then use to buy other health-promoting goods and services like buying healthy fruits and vegetables and accessing healthcare when they need it. On the other hand, loss of health could also result in economic vulnerabilities for both the individuals experiencing the health loss and also for members of the household. For example, experiencing a sudden health loss can result in high medical spending, which might then cause households to experience what's known as catastrophic health spending, where sometimes they are forced to choose between either paying for the healthcare services and needs or paying for things like food or housing and education. And not only can people experience catastrophic health spending, they can also, loss of health can also result in loss of ability to earn income, which can then perpetuate income insecurity. So, health shocks and health loss, as we've established here, can really present a major risk factor for impoverishment, especially if we consider the fact that there's a high number of Malaysian households who are living just above the absolute poverty line. Next, please. So there are three goals to a health system. The first one is to produce health. That's not just improving quality of health overall, but also the distribution of health. Second one is to actually provide social and financial risk protection. So to make sure that financial spending on health is fair. And the third one is responsiveness, which is the ability of a health system to meet the needs of the population. So here we focus on the second goal, which is to provide financial risk protection. The idea is that nobody should experience any catastrophic financial consequences of seeking healthcare. So to do this, health systems aim to achieve universal health coverage, or UHC, which here means that all individuals and communities receive the health services they need without suffering financial hardship. It includes the full spectrum of essential quality health services, from health promotion to prevention, treatment, rehabilitation, and palliative care across the life course. Next, please. So in the case of Malaysia, citizens are provided health protection through the public healthcare sector mainly. Although the right to healthcare is not actually constitutionally accorded, citizens have really become accustomed to a de facto entitlement to highly subsidized publicly provided healthcare. As very amply put by M.K. Rajakumar, the public healthcare system is a safety net for the great majority of Malaysians, and they are fiercely protective of this right to free access. So in this section, we outline 3 key challenges facing health protection in Malaysia. Next, please. So Malaysia claims to have achieved or able to provide universal health coverage for the population since about the 1980s, primarily through the generous provision of healthcare services from the public healthcare sector. Healthcare costs in the public healthcare facilities are funded by the government through general taxation and other sources of government revenue, with very minimal fees for Malaysian users at the point of use. But as we know, even before COVID-19, the public healthcare sector has been under strain. So it has a fewer number of hospitals and clinics compared to the private sector, although it does have more hospital beds, doctors, and nurses in total, as shown on the table here. But at the same time, even though it has more hospital beds, doctors, and nurses, it also has a higher patient volume compared to the private healthcare sector. So for example, if you look at hospital admissions and outpatient attendances by sector, we see that in 2019, so this is pre-COVID, 70% of total hospital admissions were in public hospitals compared to 30% in private healthcare hospitals. And for outpatient care services, 87% of total outpatient visits were in public hospitals compared to 13% in private hospitals. So clearly there's a huge need for public healthcare services in Malaysia, but years of chronic underinvestment in the public healthcare sector means that over time, it's become overcrowded and understaffed, which is made worse by the pandemic. Next, please. So, the private healthcare sector in Malaysia is framed as providing an outlet for excess demand for healthcare that the public sector is not able to meet. But because it's more expensive, it tends to cater only to higher income groups. So we see this especially for outpatient care, where patients go in for a visit at a healthcare facility without needing to be admitted. We see a clear preference for private healthcare, the higher the income group. Even then, it's still noteworthy that for the bottom 20% of the B20 group, they still need to seek care at private facilities, which may indicate that something is lacking in the public healthcare sector, that they that the poor segments of the population still need to seek care in the private healthcare sector, despite it being more expensive. For hospital admissions or just general inpatient care services, the preference according to income group is less clear. For the top 20% of households, for example, so the T20, we see a 10 percentage point increase in preference for public healthcare services, which may be a reflection of the unaffordability of the private healthcare facilities, even for the top 20% of households who may be turning to public healthcare for more severe conditions. Next, please. But despite the public sector serving a larger population, for the years that Malaysia's health expenditure data has been collected systematically, health expenditure has actually been almost equally shared by public and private sector sources. So we can see in this chart that since 1997, the public sector has barely outspent the private sector, with its share of total health spending fluctuating between 51% to the maximum at 60%. Next, please. In absolute terms, total health expenditure for both public and private sector has continued to rise at a rate of about 14% per year. And this is driven by several forces, including rising demands for healthcare due to population aging and due to the proliferation of medical technologies. But if you adjust for population size, the growth rate is at about 8% per year. Next, please. So against this backdrop of rising healthcare costs, the Malaysian government has repeatedly said that it intends to reduce public financing for healthcare. We see this first with the Fifth Malaysia Plan in 1986, which stated that with increasing demand for population by the population for healthcare, coupled with rising public expectations, the real challenge will therefore be to find ways and means to meet the rising cost of providing healthcare. In view of this, new sources of finance must be identified. So, and about 4 decades later, with the recent 12th Malaysia Plan, we see the same sentiment being, expressed with actually stronger terms. The 12th Malaysia Plan notes that rising healthcare costs have threatened the financial sustainability of the government in providing quality public healthcare, and that a comprehensive revitalization of the country's healthcare system is needed to reduce the high level of subsidies and the unsustainable healthcare financing practices. Next, please. But before we start thinking about the government withdrawing or reducing its role as a funder of healthcare services, though, it's important for us to note that households in Malaysia are already paying a significant amount on healthcare out of pocket. Out of pocket spending means that people are paying directly to healthcare providers at the point of use without any form of financial pooling, risk pooling, or prepayments. And high out-of-pocket spending is generally considered a terrible form of financing a health system, just because it puts people at risk for catastrophic health spending that we talked earlier, where they might potentially have to pay a large amount for healthcare when they face unexpected health risks. So there's a WHO framework that basically suggests that countries in the Asian Pacific region shouldn't be spending more than 30 or 40%, or shouldn't be financing their health system through out-of-pocket spending by more than 30 or 40%. And as you can see on the chart on the left, in 2019, out-of-pocket spending was responsible for about 35% of the total healthcare spending, which is quite high. But despite this high out-of-pocket share of health financing in Malaysia, we actually do see quite a low incidence of catastrophic health spending itself at about 1.4%. But it's still worrying that in 2019, 81% of households used their current income to pay for health services, with about 10% of them having to borrow money from their family and friends to pay for healthcare services. And if we can look at the chart on the right, we can see that there's a worrying trend that the B20 are actually paying a relatively high amount out of pocket for healthcare, for their healthcare needs. Next, please. So for universal health coverage provision, it's not just about how much we're paying or who's paying, it's also what we're paying for, right? And it matters a lot what we are spending on. So in the case of Malaysia, most of our health spending to date has really been focused on curative care services and not enough on public health services. And here I just want to clarify that public health services here it's different than the public healthcare sector. So public health services refers to things like preventive and promotive health services, like vaccination, screening programs, health education campaigns, disease monitoring, and other sorts of activities that are done to prevent illness and to promote health. So we see that in 2019, only 7% of the total health expenditure was spent on public health services, compared to about 70% spent on curative care. So while we can understand why for healthcare providers, when they face their patients right then and there, of course, there's a tendency for them to want to treat and cure the patients that they see. But generally speaking, public health services are actually going to be more cost effective because they actually prevent the need for curative care later on. Also, public health services are often aimed to benefit a wider population, whereas curative care services are tends to benefit individuals at a time, right? So public health services actually have a more equitable impact on improving the health of the wider population as a whole. Next, please. So given this very, very broad overview of challenges facing the healthcare system, in this paper, Ileana and I proposed 3 policy aspirations for the continued provision of healthcare protection for Malaysia. And here I pass the floor to my colleague, Ileana. Thank you.
Thank you, Naziha. So next slide, please. In this paper, we provide 3 policy aspirations to build a health system that is resilient to current and future health challenges, and I will be going through them in the next few slides. So next, please. As highlighted earlier, Malaysia's various government administrations have repeatedly expressed their perceived need to find alternative sources of financing. However, here we call for continued government commitment to financing the public healthcare system using government revenue to ensure it remains the primary provider of health protection for the population. In this paper, we argue that social health insurance, or SHI, is not suitable for Malaysia. One of the reasons lies in the nature of the revenue collection, which is through an additional payroll tax, separate from general taxes and mandatory legally mandated payments. As such, for those who are employed formally, they will have an additional payroll tax that will reduce their take-home income, and it will also incentivize workers to look for less formal or informal employment methods so that they will not have to pay for these. And this is estimated to reduce the share of formal employment by 8 to 10%. Furthermore, something like social health insurance can come with high administrative charges, and it has been estimated to increase total healthcare expenditure per capita by 3.5% with no improvements in health outcomes. The government has also tried to encourage higher uptake of voluntary private health insurance, including stating in the 12th Malaysia Plan that there will be tax relief for M40 households that buy health insurance. But this is not a sustainable way to finance a health system because, one, it is risk rated, meaning that those who are at higher risk have to are charged a higher premium, and this often excludes the lower income groups. But also in Malaysia, health insurance typically only covers inpatient care, which will encourage people to delay health-seeking behavior until their health problem becomes so severe that they need to be admitted. But tax-based financing systems can actually mobilize funds from the entire population through various forms of tax collection without needing to build a new system. Continuing with tax-based financing means we can avert the additional administrative charges of transitioning to another financing system. Despite the government's concerns that the country's health expenditure has been increasing, it's actually relatively low given our economic growth. In 2019, the total health expenditure amounted to 4.3% of the gross domestic product, with 1.9% of it spent by the Ministry of Health. In comparison, household out-of-pocket payments for health amounted to 1.5% of the GDP. Next, please. To put it into perspective, Malaysia's health expenditure as a percentage of GDP ranks 7th place amongst Asian countries, with countries such as Cambodia and Vietnam outspending Malaysia. This indicates that there is room for us to increase our spending on health. Next, please. On the subject of channeling government revenue towards optimization of resources within the public healthcare system, we call for the implementation of a comprehensive National Electronic Health Record System, or EHRs, to facilitate person-centered continuity of care and promote preventive services. An EHR is a digital record of patient health that can be shared between providers, ideally even between public and private providers. The diagram you see here is a simple illustration of how EHR works. As the patient moves between facilities such as large public hospitals, dental clinics, and even private clinics, the data generated by each of his visits is shared through the EHR system and is accessible at each point of care. Next, please. So one of the benefits of having an EHR system is that it ensures continuity of care. As I described just now, EHRs will act as a bridge between the private and public healthcare sector, which is beneficial in the Malaysian context, where patients have been shown to switch preferences between public and private facilities, depending on whether they need inpatient or outpatient care. EHRs can also be utilized to enhance care for aging population, as it will serve as a platform for further technologies, for example, SMS-based reminder systems for medication adherence. EHRs will also allow public authorities to effectively target at-risk groups and optimize patient movement across the healthcare landscape, especially in times of pandemic, where we have seen whole hospitals being closed down and become accessible to those patients, especially who have chronic diseases. Next, please. My colleague spoke earlier about the need to invest in public health services that benefit the wider population through prevention rather than cure. In this respect, EHRs can be leveraged to create a timely and comprehensive registry for health screening. In the first graph, you can see that within the Malaysian population, the screening coverage for breast cancer, cervical cancer, and colorectal cancer did not even reach 50% of the eligible population. In fact, it is significantly lower than the national efficiency standards set by countries such as the United Kingdom. According to the 2019 National Health and Morbidity Survey, a lack of screening registry was one of the major barriers towards tracking patients for follow-ups. And Malaysia also lacks an automated screening recruitment process for cancer, as seen in countries such as Denmark and the United Kingdom. So EHR implementation will be able to allow us to set in place these automated reminders to increase screening coverage in Malaysia. This holds potential for significant cost savings, as you can see in the second graph, where there is a modeling of cost savings for the United Kingdom. At 78%, the UK's NHS faces an annual direct burden of £21 million. But if coverage were to increase to 100%, the NHS would be projected to save £9 million annually, and vice versa. If coverage were to fall to 70%, the direct costs would increase by £6.5 million a year for the NHS. Next, please. A final point that we would like to raise is that the implementation of EHRs would allow us to create a comprehensive database for public health policy research and pandemic preparedness. This will allow higher levels of data accessibility, especially for epidemiological research, as done by countries such as the US and in Europe. A complete database obtained in real time would also allow cross-referencing across registries for a more holistic overview of the population, in addition to enhancing public health surveillance for infectious diseases and non-communicable diseases. Next, please. And our third policy recommendation involves health in all policies approach. While the main objective of health system is to promote health, this does not mean that it is the most important contributor to improving health status. Ultimately, health is also shaped by people's daily living conditions in which they live, grow, learn, work, play, and age, most of which actually occur outside of interactions with the healthcare delivery system. And these are known as social determinants of health. It has been estimated that between 45 and 60% of variations in health outcomes are due to social, economic, and environmental factors. In other words, while ensuring access to quality healthcare is necessary, the healthcare system on its own is insufficient to optimize the health of the population and reduce inequities in health. Next, please. To address these social determinants of health, we must adopt a health in all policies approach, which acknowledges that many social policies that cover non-health sectors typically have an outsized impact on outcomes of health and equity. For example, countries with generous pensions and employment protection schemes have a higher life expectancy at birth. Availability and accessibility of public transportation can affect access to employment, affordable healthy food, healthcare, and other important drivers of health and wellness. In Australia, amongst the unhoused population with a substance abuse issue, there was a 44.4% reduction in hospital admissions a year after obtaining public housing tenancy compared to the previous year. As such, we must move away from the notion that health is only determined by the actions of the individual and the healthcare system and start applying in earnest the concept of health in all policies. To conclude, the policy aspirations we discussed today must be taken together with the recommendations outlined in KRI's Building Resilience Towards Inclusive Social Protection report. While we propose different approaches to achieving the policy objectives, the overall goal is the same, which is to ensure that Malaysians are able to not just survive, but also thrive, able to live in dignity and good health. Thank you. Pass it back to Hawa.
Terima kasih Nazihah dan Ileana atas pembintangan tersebut tadi. Sememangnya diakui terdapat banyak pencapaian yang memberangsangkan telah kita capai dengan sistem kesihatan yang kita ada di Malaysia, sesuatu yang membanggakan, tetapi terdapat juga banyak cabaran-cabaran yang perlu kita tangani disebabkan oleh underinvestment dalam sistem kesihatan negara. Selanjutnya saya ingin berbesar hati ingin menjemput yang berbahagia Profesor Adiba untuk memberi sedikit ulasan dan pandangan berkaitan pembentangan yang telah kita dengar sebentar tadi. Silakan Prof.
Assalamualaikum dan terima kasih Hawa and thank you to KRI, in particular to Tan Sri Nur, Nazihah and Ileana for inviting me to say a few words about this excellent series of reports that you all have put together, and in particular today's discussion. I think having lived through 2 years of the COVID-19 pandemic, it really is we've come at an important time to seriously discuss the state of our healthcare system. As pointed out by Naziha, many attempts by many government administrations to address the healthcare system have been over the years, but there's no time better than the present to seriously look into this. And we saw firsthand what happened when there's chronic underinvestment in the public health sector, as we did during the COVID-19 pandemic. I think it's not an understatement to say that the poorer than expected outcome of our COVID-19 pandemic response that led to many more people becoming infected and higher death rates compared to many countries of our economic status and in the region is a direct result of the underinvestment in the public health sector. Number one would be like you pointed out in your report, the public health services as opposed to the public health care, as in our colleagues in the PKDs, who are the first responders in terms of disease notification, in terms of contact tracing, etc., because everything many things were done manually, and there was not enough search at the time of the Delta wave. We saw the consequences of that. The other lesson learned from the COVID-19 pandemic was also this dichotomy between public and private health sector when it comes to acute care. At the height of the chaos, if I can call it that, between July to October, when public health hospitals, including teaching hospitals and of course Ministry of Health hospitals, were filled to the brim with hundreds of people waiting in emergency department. Unfortunately, although that there were beds, I think, in the private health sector, it was really a struggle for us all to expand the services to the private health sector, because it's a real separation. I mean, kudos to the Ministry of Finance for allocating, not an inconsiderable sum to the private health for us to decant the non-COVID patients to private hospital, but there was considerable delay. That probably led to less than better outcome than expected. So I think to connect your report with recent events, I just want to make this urgent call for a really serious look at our healthcare system. As you said, we've done well, considering that only, less than 4% of GDP is allocated to healthcare. But aside from the pandemic, there are other urgent reasons why we need to relook at how we structure our healthcare, whether it's in the financing or the division between allocation to the preventive care versus the acute care. And as you rightly pointed out, the aging population, the rise in non-communicable disease, particularly diabetes, that's going to lead to increased number of people with chronic renal disease and eventually end-stage renal failure and dialysis, the rise in cancer. My colleague, Professor Nirmala, had also done, I'm sure you came across the report in terms of out-of-pocket expenses for people with breast cancer. And I think approximately 50% of Malaysians out of the 1,000 or so who were interviewed had catastrophic financial outcomes as a result of cancer diagnoses. And you've also very nicely documented that in your report. Don't forget, I think for Malaysians, they don't just seek conventional Western medicine, but there's also substantial out-of-pocket expenses that may not be as well documented for those also seeking complementary and traditional and alternative medicine that's not cheap either. So for all those reasons, I really welcome this report that's highlighted the need for, I think, obviously much more details and much more studies. Well, there's been a lot of studies, but to really nail down what needs to be done very quickly is important. I particularly like your call for investment in digital technology. It's not just EMR, it's not just EHR. I think obviously, as you know, the ministries of finance and EPU are going to balk at the outlay, the initial outlay that these things are going to need, obviously, to put in electronic health systems and digital systems. But I dare say, as you pointed out, eventually this is going to pay in itself in terms of streamlining the care between community-based care and hospital care, etc. Now, one thing your report didn't touch on, which has been a hot issue in the last few months, and something that I personally have a lot of interest in, is of course the human resource for health, as it's called. Part of the struggle we've had in terms of overcrowding is the understaffing, as you rightly pointed out. And so, for those of us who are advocating for our junior colleagues to be absorbed into the healthcare system, we're producing several thousand a year, and there's a block because there are no posts, as JPA calls it. This cannot continue because the population is increasing. We've already, in terms of the ratio of particularly specialists to the population, already way below, OECD countries. Okay, let alone OECD countries, even countries of our income level. So that's going to take a big chunk of the health expenditure, the training as well as the salaries going forward. So I welcome your call for increased investment through continued government. From government revenue. I'm no expert in health financing. I would leave that to Tan Sri Noor. It's just that I want to say that yes, we must put more money into the healthcare system. How you do that, I'll leave to the experts like Tan Sri Noor to figure out. Because in the end, we've seen the result of this underinvestment. We cannot go through another pandemic, and all the experts around the world are saying that this is not going to be the last with the current state of our healthcare system that obviously needs improvement in many areas. So whether it's more hospitals, more better primary care services, better preventive care, as well as increased human resource for health. Let me say that, putting more money is obviously very important, but putting more money where it matters is even more important. And I think you touched on that as well. So digitization is obviously important. Preventive care at the moment, it's 70-30, that cannot continue. There are many evidence-based cancer screening that you also rightly pointed out that we're not doing satisfactorily. Colorectal cervical cancer and breast, and these are very cost-effective, screening, and I think community-based care. This is one thing that again, not much discussion in Malaysia around it, but strengthening community health-related community organizations, community NGOs properly, giving them support, financial support, as well as technical skills and accreditation, I think will also, in the long run, be cost-effective, particularly in the care of the elderly, chronic people with chronic diseases, and those that are in need of community-based care. I think a chunk of that financial investment needs to go there, because at the moment what we're seeing is for lack of good primary or accessible and strong primary care, including community-based care, the default is to go into hospital. A lot of elderly people in nursing homes, for instance, when they deteriorate, go to expensive acute care hospitals instead of being managed in the community, because there aren't enough people experts in this to provide that care in the community. So so there are many issues that have arisen, I think, from your excellent report that you probably need another report. But I hope that your recommendations will be taken up very soon. So congratulations, and thank you very much for inviting me to give my thoughts on the issue.
Terima kasih banyak kepada yang berbahagia Professor Adiba. As she rightly pointed out, putting more money is important, but where we put the money also matters. And hence why there are few suggestions that are putting here that we should be putting more resources on the record system, on preventive care, as well as I think we also need to also take care of the medical practitioner, of the people who are really serving to take care of us Malaysian. Baik, kita akan membuka ruang soal jawab sebentar lagi bagi memberi ruang kepada hadirin untuk mengemukakan sebarang pertanyaan melalui butang Q&A. Tapi sebelum itu, saya ingin menjemput yang berbahagia Tan Sri Nur Muhammad Yaakob, pengerusi KRI, untuk memberi sedikit rangkuman dan ulasan bagi perbincangan kita pada petang ini. Dipersilakan Tan Sri.
Assalamualaikum warahmatullahi wabarakatuh dan salam sejahtera. Terima kasih Puan Hawati. Thank you very much Datuk Professor Dr. Adiba and Naziha and Liliana for excellent contribution, and thank you Professor Adiba for all your support for the initiatives and recommendations of KRI. For the year 2022, the budget allocation for health is 28 billion. Looks like it's very big, but as we realize, we need more. But as Professor Adiba said, we need more, but we have to put that money where it matters: electronic health records, in human resource, etc. Pada masa ini kita nampak, sungguhpun angka itu nampak besar, 28 bilion. Sejumlah besar peruntukan di Malaysia, peruntukan untuk kesihatan, biasanya disalurkan untuk kos rawatan penyakit. Sementara perbelanjaan bagi usaha pencegahan, prevention, pencegahan penyakit masih rendah. Sebagai misalan, pada tahun 2019, 68% daripada jumlah perbelanjaan kesihatan adalah bagi rawatan penyakit. Sementara hanya 7% untuk usaha pencegahan. Walaupun memang benar aspek rawatan seperti perubatan, pembedahan adalah penting, memang penting, tersetuju penting. Tapi usaha pencegahan penyakit melalui saringan kesihatan, melalui pendidikan, nutrisi, makanan, dan secara amalan hidup sihat masih berkurangan. Oleh yang demikian adalah penting untuk kita memberi tumpuan kepada pencegahan. Memandangkan tumpuan kepada aspek ini akan memberi pulangan, returns yang tinggi, memang tinggi dalam jangka masa sederhana dan jangka masa panjang. Dengan mencegah penyakit daripada berlaku, kita akan mengurangkan kos rawatan yang perlu dibelanjakan di kemudian hari. Saya bagi satu contoh. Kajian menunjukkan bahawa usaha pencegahan boleh mengurangkan kadar kematian akibat penyakit jantung sebanyak 78%. Risiko penyakit kencing manis dan darah tinggi juga boleh dikurangkan melalui langkah pencegahan. Usaha ini bukan sahaja menjimatkan kos, memang menjimatkan kos, malah mampu meredakan kesengsaraan pesakit serta meningkatkan daya tahan terhadap penyakit berjangkit seperti COVID-19. Kita harus mengamalkan pendekatan kesihatan dalam semua dasar seperti yang disebut oleh panelis tadi, health in all policies. Memandangkan kebanyakan faktor yang mempengaruhi tahap kesihatan berada di luar kawalan Kementerian Kesihatan. It's beyond the scope of the health ministry. Dianggarkan sehingga 60%, itu angka yang tinggi memang, 60% daripada health outcomes ditentukan oleh faktor sosial, faktor ekonomi, faktor persekitaran, dan dalam kata lain, walaupun akses kepada perkhidmat kesihatan berkualiti adalah penting, dan kita memang mempunyai akses yang berkualiti to some extent, sistem kesihatan semata-mata tidak mampu untuk meningkatkan tahap kesihatan secara keseluruhan. Terdapat beberapa faktor sosioekonomi yang melangkaui bidang kuasa Kementerian Kesihatan. Salah satu penyumbang terbesar kepada tahap kesihatan yang rendah adalah dari segi pendapatan. Khasnya gaji yang rendah. Some suppression of wages in our country. Pekerjaan yang tidak menentu, insecure workforce, gig sector, serta persekitaran kerja yang tidak kondusif dan berbahaya. Faktor-faktor ini boleh menyebabkan kemiskinan, di mana kemiskinan juga merupakan satu faktor yang boleh memburukkan tahap kesihatan seseorang. Sebagai contoh, apabila seseorang ahli keluarga, terutamanya pencari nafkah, jatuh sakit, seluruh keluarga mungkin terperangkap dalam kemiskinan. Kumpulan berpendapatan rendah lebih mudah terjejas memang, kerana mereka menghadapi keberangkalian untuk sakit yang lebih tinggi. Selain itu, persekitaran rumah yang tidak kondusif, kekurangan sokongan semasa usia awal bagi kanak-kanak, serta amalan pemakanan yang tidak sihat juga banyak mempengaruhi tahap kesihatan. Kita di KRI telah melakukan banyak penyelidikan dalam aspek ini dan telah mengemukakan banyak juga saranan kepada kerajaan. Walaupun objektif utama polisi sosial ini bukan bermatlamat meningkatkan tahap kesihatan, namun ianya mempunyai banyak manfaat dalam meningkatkan tahap kesihatan rakyat. Justru, tuan-tuan dan puan-puan yang dihormati sekalian, justru itu pendekatan the whole of government, the whole of society adalah diperlukan untuk membina daya tahan sistem kesihatan, untuk membina daya tahan sistem kesihatan negara, untuk menyediakan perlindungan kesihatan untuk semua. Terima kasih Hawa.
Terima kasih banyak yang bagi Tan Sri. Seperti yang Tan Sri nyatakan tadi, walaupun kita banyak juga bergantung kepada Kementerian Kesihatan untuk menjaga kesihatan kita, tetapi banyak juga keterbatasan kementerian itu kerana ada banyak juga faktor-faktor yang berada di luar kawalan Kementerian Kesihatan yang boleh mempengaruhi tahap kesihatan rakyat Malaysia. Seperti yang saya katakan tadi, faktor-faktor ekonomi, faktor-faktor sosial dan faktor-faktor persekitaran juga memainkan banyak peranan dalam mempengaruhi tahap kesihatan kita yang perlu juga kita beri perhatian. Baik, saya ingin meneruskan webinar pada hari ini dengan mengambil beberapa soalan yang telah pun dihantar oleh para hadirin sekalian. Okey, saya ingin memulakan dengan soalan pertama ya, daripada okey, namanya tidak dinyatakan di sini, walau bagaimanapun saya akan bacakan soalannya. Yang pertama, would Malaysia two-tier health system be a barrier to implement electronic health record? I reckon system used between and within public and private sector are different. If so, do we need to move away from two-tier health system? Ya, menarik soalan di situ.
Okay, Hawa, I think I'll answer a bit and then if anyone else wants to add. So you are right to point out that the two-tier health system is a barrier towards EHR implementation, but I don't think that we need to move away from this two-tier health system because it has served us well. I think the point is that EHR implementation in public facilities would already have a large impact because we're able to connect the ecosystem between klinik kesihatan, large hospitals, and dental clinics, for example. And then hopefully, once we have a really good enough system, and that's why we're advocating towards really thinking through the governance and the implementation of these EHRs, once there is a good enough system by the government, the private providers would see value in jumping on and using this system instead of using their contracting private vendors to do it, which is higher cost to them. And the full benefits of EHR comes when you have an interoperable system. So I think once we get the public sector fully utilizing EHRs, you're able to set an example for the private sector and they will want to come on board. Prof. Adipa, you had something?
Yeah, I think there are two sort of separate but interrelated issues, right? One is a more technical issue. Are they interoperable? And I believe these days, you know, with the IT solutions, anything is possible, right? To integrate the two. The concern is, of course, around PDPA. But again, you know, with the right framework, the right legislation, all that should be able to be overcome. The good thing, the important thing, I myself don't know too much about these big databases, but the good thing about Malaysia is we have that unique identifier, which is the identity card. That's already a big step forward in terms of unifying our health records. And we want a good example of what having you know, this national health records, you just have to look at Israel. The reason why Israel, of course, it's a much smaller country, but has been able to respond the way they have with all this impressive rollout of vaccine and you know, research that's come out very quickly, is because they've got this national electronic health records. So there are many advantages to it, and you know, for the person who's asking, I think the barriers in terms of the technological, I'm pretty sure can be overcome. It's the regulations and PDPA and things like that probably requires a lot more thought. But that shouldn't be the reason why we abandon, I guess, the two systems. The two systems, you know, are too entrenched. I think even if we want to, I mean, there are many reasons. You know, I'm a champion of public healthcare, but and would rather see that we totally invest in public healthcare. But realistically, the private health sector, which by the way, a lot of it's owned by the government as well, it's too entrenched for us to reverse, I think. So we need to find ways to make the two systems work together better.
Baik, terima kasih Prof. Menarik sekali poin yang Prof. Adiba highlight just now, which is on my card. I think itu satu aset yang Malaysia ada, yang potensinya masih kita belum optimumkan sepenuhnya dari segi data lah. Okey, kita akan mengambil soalan seterusnya juga daripada somebody yang we can identify siapa, tapi it's okay. So soalannya, is there a practical way to implement health for all policy? Okay, something systematic for ministry to follow contohnya. Okay, mungkin kita boleh detailkan apa makna health for all ini dan bagaimana kita boleh laksanakannya.
Yeah, I'd be happy to take on this question first. So there's this thing called a health impact assessment tool, which is, like perhaps the audience has heard about environmental impact assessment tools, right? Where, before starting a construction project, for example, you have to do this environmental impact assessment. So you can do the same thing with health through a tool that's called a health impact assessment. And this is actually something that there are certain governments in Spain, for example, that have implemented this in their ministries, so that when they decide to, before they start to build or give approvals to build grocery stores, for example, you can look at the impact on the neighborhood before you improve things like public transport, for example. You can take into consideration as well the potential impact on health. So this is something that that's quite practical, that ministries can do to really start to acknowledge that all social policies essentially have an impact on health. Yeah.
Baik, terima kasih Naziha atas jawapan tersebut. Okey, saya akan ambil soalan seterusnya yang berbunyi, healthcare inequality ataupun unequitable healthcare formulation. As pointed out by the Protect Health CEO, in healthcare, it is not so much as equal treatment for everyone, but a more equitable healthcare system which provide more protection to the poor and vulnerable. What can Malaysia do in this regard, especially in healthcare financing?
I'm happy to take that on as well. So that's a huge question. But I will start by saying that there are certain things that we can look into, right? For me, basically, why we are calling for a tax-based financing for the public healthcare sector especially is because it is the most equitable way. You can make it very, very progressive so that the rich are essentially, if they're taxed more properly, then they're paying, they're cross-subsidizing for the poorer segments of the population. And I would also add then, we have to start also thinking about, when we give things like tax reliefs for, like, for example, something that was recently announced, you can claim up to 10,000 ringgit in taxes for self-testing, for example, for COVID-19. And of course, while we want to welcome things like, increasing frequent testing for COVID-19 as part of our response to the pandemic, we also have to think about who this benefits, right? And something like tax reliefs, for example, will only benefit people who are already earning enough to be claiming taxes anyway. Whereas if we didn't give these sort of tax incentives or claims or reliefs, that revenue actually could be used to then, give support for the lower income groups to buy or to give free testing kits, for example.
Okay, terima kasih Naziha. I think the key here is progressivity in terms of our tax system, right? Okay, moving next
If
to
I
the.
may, Howard,
Oh, yeah, sure.
I think we cannot talk about inequality without talking about, the non-Malaysians who make up a substantial number of individuals living in this country. Yeah. So how to finance the migrant workers, whether they're documented or undocumented, it's always been a major headache, right? For the country. We charge them when they come to even public hospitals twice the cost of what we would charge Malaysians. Now you can debate this, the merit of this or not, but what it does is it puts fear, and I think one of your reports stated this. I think one of the reasons why your report on migrant workers, you know, the fear of the cost of healthcare, and not to mention the fear of being incarcerated and deported, etc., prevents the migrant workers from coming forward for care, much less preventive care. So what we end up seeing in our hospitals is people who come in extremis, you know, which then, you know, they end up in intensive care, etc., which you know, adds to the cost, overall cost of healthcare. So I think a debate, a discussion around how we can improve our healthcare system must also include a discussion around how to provide, you know, equitable care for the migrant workers, who are essential part of the economy. I mean, we constantly want to turn a blind eye to the need for them, or you know, othering them, but in reality, if we don't include them in, you know, in a meaningful way in these discussions, the cost in the long run is probably going to be higher, as we saw again with the COVID-19 pandemic. You know, the disruptions, the economic costs, not to mention the hospitalization and the brought-in deaths, yeah, as a result of the inequality.
Yeah, I think if we can agree that social protection and protection for health is a right for everyone, so I think it is a moral call that we slowly have to progress to provide this essential protection to everyone that reside within our boundary, I suppose. Thank you, Prof. Okay, I will go next to the next question, also from anonymous attendee. The question is, are there economic or social reasons why private healthcare is prominent in Malaysia? Is it a major contributor to our economic activity, or is it just there because those who can afford it demand it? Because your slide show a large majority of Malaysians seems to rely more on public sector for healthcare, I suppose. Yep.
I can start it a little bit, maybe. I mean, I will say that a lot of these things, public health decisions, are often also political, right? They're economic and they're also political, and you know, there was a big movement for privatization of services in the 80s and 90s, and that could be a big part of why we do have, as Prof. Adiba mentioned, a very entrenched private healthcare services sector in Malaysia. You know, proponents for the private healthcare sector do say that they exist because it's to serve the excess demand that the public healthcare sector cannot meet. But then, I mean, you can question about whether or not it's actually true that the public healthcare sector cannot meet, or the government is unwilling to commit enough to meet those excess demands, right? So I guess that's more of an ideological question that we can maybe debate at another time. Yeah, thanks.
Thank you, Nazia. Interesting question and interesting discussion on this issue. I will just go next to the next question by also an anonymous attendee. The question is, what is KRI position on the idea for a national health insurance system? Okay, from the presentation, it appears that KRI is against the notion. Could you expand on why? Related to this question, do you advocate for higher taxation, for example, maybe GST, to fund the healthcare system, or a reallocation of current tax revenue levels?
I can take that on a little bit. First of all, I want to just give a caveat that the views here are really of the authors, i.e. me and Ileana. They don't necessarily represent the views of KRI. There might be others who disagree. But for us in this paper, we do make a case against having a social health insurance or a national health insurance system because there are several reasons. The big part of it is basically that it's an additional income, payroll income tax, payroll tax that would have to be borne by usually formal workers, because you know, the informal workers are often not captured by the tax system. And then it comes at an increase of cost. There have been studies that estimate that it costs about an additional 3.5% per capita per person to transition to a social health insurance system. And a lot of this cost actually goes to administration, right? Because you have to create a whole new system, a whole new entity to collect the revenues, to then disperse the funds, et cetera, and especially, like, you know, employment status, especially in Malaysia, is not static at all, right? So as people move in and out of different employment status of, you know, formal to informal work, these are some of the kinds of administration that the social health insurance body would have to keep track of. Whereas, you know, you can use this money, at least for us, what we're arguing is any additional expenses that we do make for healthcare in Malaysia should be spent on resources, or should be spent on hiring more workers, you know, expanding access to primary care services, etc.
Okay, thank you, Naziha. I think the key here is pragmatism, because I think we have to acknowledge that the system that we currently have has served us quite well. I think what is important is to really improve the existing system rather than try to move to a totally different system that we might face challenges in implementing it. Okay, I saw a few hands raised up by Tan Sri and Prof. Adiba. Probably I can call Tan Sri first.
Yeah, okay, thank you, Wati. On this issue of tax, we believe that there are ways for the government to optimize on tax. Basically to say that the government is, we don't believe the government is really optimizing on these tax measures. You know, in terms of the tax collected as a percentage of GDP, we are one of the lowest in the world. So our tax system is not robust. The GDP goes up, but our tax do not go up as much. And there are many reasons to it. Of course, in every budget, we try to do that. But to answer the question is, yes, we think we can raise more taxes, even GST, if need be. And we think that we can review the allocation to different sectors in such a way that we will be able to spend more on health. We think that it'd be good for us to spend more on health, not necessarily Ministry of Health, but health even in other ministries relating to health. Because in the long run, this reallocation, collecting more taxes from those who can afford, and to create this equal system and a system, more progressive system, but basically a system where the next generation of Malaysians are healthy. It's very important, because do you know that more than like 20–30% of our Malaysians are either stunted, obese, not well fed, etc. So there are many long-term issues that need to be thought through in a long-term frame of mind, and the whole tax system, revenue system, allocation system will have to look through to make sure that the next generation live a healthy life. That's very important. And if taxes have to be changed and raised, it will have to be done. And I think it should be done. Thank you.
Okay, Prof, do you want to respond?
Okay, I want to be a devil's advocate on two matters. One is in terms of payroll tax, Naziha argued against it because you have to create a whole new system, and much of the revenue from that is going to go towards administration and you know, building new buildings and paying administrators to run this. Tell me why, and I'm asking this very innocently because I don't know these things, right? Why can't it be part of the EPF, for example? So that's my first question, devil's advocate. So ring fence some of that payroll tax for health. And secondly, I completely agree with Tan Sri, know that there's so many, I mean, you know, the some of the things we discussed today are just tip of the iceberg in terms of truly addressing, you know, sort of health. We know that Malaysians are living longer, but they're not necessarily living longer healthier. So that's going to further add the dollars. Now, I think it was 3 days ago that I read in the papers that the government wants to push health tourism again, and you know, looking at that as a source of revenue. I have my own reservations about that, to do with, you know, internal brain drain, etc., etc. But if this goes ahead, why can't the profit from there, as well as the current profit from the GLC's associated private healthcare, be ring-fenced again for health, whether it's to, you know, to finance more, you know, training of more doctors, or bringing more doctors, nurses, etc., etc., and build more clinics, hospitals, because these are GLCs, you know, whether it's Subang Jaya Medical Center or KPJ, or I think Pantai previously was, but it's not now. So yeah, that's my two questions.
Interesting thought that okay, very interesting thought, Prof.
Coming from a non-finance person, Tan Sri.
Yeah, just one small matter, but I think it's a good idea. We use DLC revenue and profit to provide this extra funding required. But the one issue is that this DLC hospital doesn't belong to GLC itself. We are just part owners, and the other owners are private sector, and sometimes it's listed. So there's all this compliance we have to follow for, you know, Bursa and security commission, etc. So we cannot really take out the money and use it because it belongs to so many people. So there's one constraint.
I see. I told you I don't understand finance. Okay, very simplistic way of thinking, but you know,
it's a good idea, but just we have a big constraint.
Yeah.
Okay.
If I may also add to your second point, Prof. Adiba, it's also worth noting that most of the healthcare services that are being used in the private healthcare services are actually paid out of pocket, right? I think it's about 93% of it is paid out of pocket rather than through insurance or anything like that. So if we take that profit is actually again coming out of pocket from private households. So in terms of sustainability, in terms of cross subsidizing between the rich and the poor, I'm not really sure how that really works, because the idea is that we want to reduce out-of-pocket expenditure, right? So yeah, and I wonder if Hawa has a response for whether or not we can include some of the health financing from EPF, because she has done a lot of work regarding EPF coverage.
Interesting point that Prof. Adiba has highlighted in terms of tapping into resource availability of our, not only EPF, probably SOCSO as well. They have some coverage that they try to cover in terms of health related risk, despite it is more on occupational health related risk. But I think one of the challenge that probably these two institutions would still continue to have or face right now is in terms of coverage. For example, we know that memang satu adequacy in terms of retirement saving is already a problem under EPF, but not only that, the people who are part of EPF system is also not everyone is there. If you're looking in terms of working age population, only we still have about 40% not part of the system. But if we expand a bit further in including those who are in working age but not in labor market, this amount, the share is about 60%. And then if we add those who are outside working age as well as children, then we will have a larger population which is not part of EPF or SOCSO. So it will be quite a tremendous effort that we have to put in to ensure that everyone is protected in terms of health. I think one of the reasons I think we are a bit worried is that we because health and this issue of death is something that we want to protect everyone against, and we cannot, I think, let income be a determinant for someone to determine their access to these services. Okay, I'll take next question by Rui Z. Sid. Sorry if I hope I say the name correctly. Okay, the question is there a possibility for MOH to collaborate with private healthcare providers in the implementation of healthcare financing or health insurance, the way healthcare works in countries like the US? This would improve unequal access and efficiency of the system.
Thanks for the question, Racy. So private health insurance is definitely a complicated issue anywhere, but also in Malaysia. First, I just want to address the fact that in the US, the fact that they have to rely so much on private insurance has been one of the reasons why their healthcare costs is one of the highest in the world, but they have quite little to show for it in terms of life expectancy, healthy life expectancy, etc. So there's a lot of evidence that shows that the US system of private insurance doesn't really work. So in terms, and whether or not we can bring it to Malaysia, collaboration between MOH and private healthcare providers, especially for health insurance, I think I will say that private health insurance in Malaysia is really not well regulated at all. First of all, they're only affordable mostly for the very high income groups, right? And then a lot of the lower income groups who also tend to have a higher concentration of health conditions, they're often excluded from private health insurance just because of either high premiums because of pre-existing conditions, or some of the health insurance systems in private health insurance system in Malaysia works by claims, or it doesn't cover the primary care services like going to the clinic, for example. It only covers if you're admitted to the hospital. So basically, for us to rely on or start to count on private health insurance to relieve some of the financial burden of healthcare in Malaysia, I think first we would need to do a lot of work on the private health insurance providers, which I don't think will happen anytime soon, just because of conflicting interests and whatnot. I hope that answered the question. Thank you.
Okay, thanks, Naziha.
Don't say that, Naziha. I just had a really good town hall meeting with that was hosted by Bank Negara and a whole slew of insurers from Malaysia to discuss the inclusion of, believe it or not, of people living with HIV to allow them to take up health insurance because of the advances in HIV medicine mean that people living with HIV can lead an essentially normal life and a normal lifespan. So we began to discuss this, and we also had discussions with Bank Negara and Liam in terms of removing HPV, DNA, or cervical cancer as a sexually transmitted disease. Because of that, people who want to do HPV DNA testing, which is a more modern test for cervical cancer, which I think we want to push prevention care. This is one of them. WHO wants to eliminate cervical cancer from the world, right? And the best way to do that is with vaccination as well as HPV DNA testing. But the costs of HPV DNA testing currently will not be reimbursed by insurance because having a positive HPV means that it's a sexually transmitted disease. So we've begun to have these discussions hosted by Bank Negara and Liam, and hopefully we'll see these more progressive policies come through, both for HIV and HPV.
Yeah, inshallah, hopefully, yeah. Thank you, Prof. I think I'll take the last question. This is from Kanmani Batumalai from Code Blue. I think this question is specifically addressed to Prof. Adibah. The question is, as we are still saying to strengthen our public healthcare system, what do you think about the proposed amendment in Act 342 which will impose a minimum fine of 10,000 ringgit for those who violate COVID-19 SOP. This act will also applicable for other communicable diseases like dengue and TB. Will harsh punishments work in public healthcare system?
Yeah, I think this has become quite controversial. In general, I think criminalization of behavior for, as a deterrent for infectious diseases have not been shown to work. And what it will do is, people will find ways to overcome this, is number one. Number two, it's also going to result in, once again, the inequalities, and people who can get away with it will get away. People who can't are going to be the ones, ending up in prison and paying the 10,000 ringgit fine because they don't know someone or whatever it is. And then, of course, the third is concern around corruption, that it will give opportunities for those on the ground to use it at their discretion. So I am for, I think, looking at the flouting of laws, current laws, by, say, industries that, the enforcement of this should be more, and perhaps proportionate to the size of the factory or the income, etc. But imposing this on individuals, I have my reservations.
If I can add, Hawa.
Yes, sure.
Yeah, I totally agree with Prof. Adiba, and for several reasons, right? The first one is, like, we talk about addressing causes of ill health, right? We also have to understand the causes of behaviors that cause ill health. So if people aren't following or certain rules, for example, we also have to look at why they're not able to follow certain rules. You have to think about, for example, maybe for certain lower income groups, they're not able to go for testing, or they're not able to forego, or they're not able to buy masks that they need to go to work every day. Those kinds of things really matter. And the other thing as well is a 10,000 ringgit fine for somebody who's in the B40 group is, talk about catastrophic, right? That could be extremely catastrophic. But for a very, very high income person, for example, that's pocket change, right? So we need to also think about whether or not these sort of regressive methods are actually useful. Thank you.
Yeah, I think, whether it's COVID or other diseases, the most important thing in public health response is trust. And it's been shown over and over again that trust is the most important, one of the most important. Trust in government, trust in the messaging. So we need to strengthen that before using the criminal justice approach, which we are apt to do here in Malaysia for a lot of things. And so better risk communication, better engagement with the community, and especially community leaders. These are all going to take time, and but also being consistent. So we already have so many, even during the emergency, right? We were not able to control because there was this loss in trust. It's not that we didn't have the instruments then. But because there was loss in trust, people, and there were all these perceived, maybe not so perceived, double standards that kind of didn't help matters at all. So I am not sure having more stricter and more expensive fines is really going to be a deterrent. It may deter some, but overall it may not bring about the desired outcome.
Baik, terima kasih Prof atas respon sebentar tadi. Saya rasa itu sahaja yang masa yang kita ada untuk hari ini. Saya sangat-sangat menghargai soalan-soalan dan perbincangan yang kita telah bincangkan pada petang ini. Sangat menarik sekali perbincangan pada hari ini, dan sekiranya ada soalan-soalan lain yang ingin dikemukakan, kita sangat-sangat berbesar hati untuk menerima dan menjawab soalan itu. Boleh hantarkan soalan dengan emailkan soalan kepada krievents@kriinstitute.org. Bagi yang ingin mendapatkan maklumat lanjut tentang penyelidikan KRI, sila muat turun di laman web KRI di www.kriinstitute.org, serta ikuti juga perkembangan terkini melalui platform sosial media KRI di Twitter, Facebook, Instagram, LinkedIn KRI. Terima kasih sekali lagi atas penyertaan para hadirin sekalian. Untuk makluman, rakaman webinar dan rumusan bagi acara pada petang ini akan dimuat naik di laman web KRI. InsyaAllah kami amat berharap untuk bertemu lagi semua pada tahun hadapan. Dan please take care. Terima kasih dan Assalamualaikum warahmatullahi wabarakatuh.